Purpose of today, a couple things, is high yield stuff for your paramedic test. Okay, we're going to go over what is going to be on that test in the setting of what they want, the basic core stuff that they want you to have. The core stuff's great. You've got to know it. It's good to know for when you're doing real life stuff, but some of it is not necessarily, you're not going to see a test question about it. Does that make sense to you?
Yeah.
So we'll rock through the lecture part of this pretty quick, and working getting you guys out of here right about in an hour so we can just get out of here and go on with our day. Sound good? I'm one of the ER attendings. You'll see me down there. We'll have fun. We'll try to get you chest tubes and intubations and as much as we can do. And are you guys starting IVs on everyone you get a chance to? You should be banging the IVs out because you're going to definitely...
Yeah, we're just on ultrasound at night. Like
okay.
And there's Dr. Brand just there.
Yeah, Dr. Brand
ultrasound.
A lot of ultrasound IVs. Do you have, because you have ultrasound equipment with you, right? When you're in the field, if you're in the medical role?
Right. If
maybe.
So,
yeah, depending on which battalions they end up, a lot of them will have...
okay. All right.
There's
well,
a big push for it.
Whatever Brant says goes, right? So he knows what he's talking about, that's for sure. So basic about the heart, the action potential, you guys probably already understand a little bit about this. The heart, the cells depolarize, causing sodium and potassium to influx and efflux, and that causes the muscle to contract, causes the actual electrical activity in the heart. All an EKG is, you guys, is the tracing of this electricity. That's it, okay? It's not, I know they sometimes are pretty intimidating, but all this is squiggly lines on a piece of paper that measure that little bit of action potential, that little bit of electricity. This is no different than if you took a bomb or just a tannerite explosion and you put cameras all around it. All, had 12 different cameras filming all at the same time from different angles, and then shot the tannerite and it went off, and you go and look at each camera, the video is going to look a little different, right, from each angle. That's all these leads are catching that electrical potential from a little bit different angle. That's it, okay? And if you kind of think of the EKG like that, it might all come together when we talk a little bit later, and you're going to be pretty much like, you're going to be like, I got EKGs. I'm not worried by them anymore or threatened by them at all, okay? Super important to remember is where this stuff happens at within the heart. This is test question material big time, okay? And so one of the things I recommend you do, you don't really have notebook paper, is to make yourself a basic diagram of the heart, which is going to be a kind of an oval shape, and then take a line and cut it into fourths, okay? And that way you can label your ventricles and your atrium. So here we have the right atrium. Right up here in the right atrium lives your sinoatrial node, your SA node. That's where the heart starts its beat, okay? Because that's where the heart starts its beat, that's going to be the first little electrical blip you see on your EKG. That's the P wave, okay? So if you look on your EKG you got on your desk and find a P wave, that P wave is just this part of the heart firing. That's where it starts. And that's why your P, Q, or S complex on your EKG starts with the P wave, because it's the first area that depolarizes. Then that electrical charge goes here to the AV node, okay? The AV node resides right there. Anyone know the purpose of the AV node, what it does?
To back up for the SA node.
Okay, kind of, sure, that does. Okay, it relays the information, but what does it do? It slows that conduction down, because the SA node fires, causes the atrium to contract, causes everything to happen. If it just went slamming through here, you wouldn't have any time for this to fill up with blood, yeah. And as you guys are going to learn, if you haven't already, you need these chambers full to pump well, right, to get good cardiac output. So the AV node causes the conductivity into this part of the heart to slow down, okay? So if you think about it for a second and put this in your mind, just think about it. If you have problem with your AV node, if there's a problem, let's say this part of the heart doesn't get good blood flow, and you knock out the AV node or you cause a problem to the AV node, what might that do if the AV node's not working properly and the conduction now can't get through the heart? So the electrical input can't get through the AV node. Would the impulse be allowed to continue on and the rest of the heart to contract?
Probably start firing by themselves.
Yeah, they could start firing by themselves, or you get a block. Exactly, the electrical impulse stop. That's an AV block. You're going to learn about that in a minute. Those are testable AV blocks, right? Type 1, the Mobitz, Winky block. You've heard those terms. Those are testable things. And that's where that happens, right there. And it's simply an AV block, so you're not missing it. It's simply the conduction through this area isn't working well. Okay? Now, I'm oversimplifying it. You guys met Dr. Garner yesterday, who's actually an electrophysiologist of the heart. This is all he does is study this stuff, and he could probably go into so much detail, he'd have all of our heads spinning. But for your test, what you need to know is that AV node delays conduction through the heart, and when it's not working right, you get heart blocks, AV heart blocks, okay? And we'll talk more about this. So then that impulse drops down into this area and through here, the interventricular septum, and is spread out through the heart via these Purkinje fibers, okay? And then that causes the depolarization of the ventricles to contract and send blood either to the lungs or out into the body, all right? Does that kind of make sense to you? So we got our P wave, that corresponds with this contracting, the SA node. This PR interval, okay, that's from here to here, and we'll talk more about that, is simply the time it takes the electricity to get from here and start the ventricular contraction, the PR interval, okay? We'll talk more about that too. All right, let's move on. Accessory pathways. This slide is a little bit early in the lecture. They snuck it in here on us, and I think you just said you can have other areas of the heart that depolarize and cause heartbeat. So what this is saying is that there are other areas of the heart that can initiate a heartbeat. And when that happens, you get weird rhythms like SVT, okay, atrial fibrillation, stuff like that. And we'll talk more about this. So this is an important slide to remember. For as basic and as simple as this is, if you understand this concept that we're just going to talk about, you're going to get at least one test question right, okay? So the autonomic nervous system is broken into two parts, sympathetic, parasympathetic, right? So parasympathetic really controls a lot of the heart at baseline, okay, parasympathetic. Do you know the hormone or the chemical that is released by the parasympathetic nervous system? Which one? Is it norepinephrine or acetylcholine? Acetylcholine, it is. You're exactly right. And does acetylcholine slow the heart down or speed it up? Slows it down, absolutely. If your heartbeat gets too slow, what do you counteract acetylcholine with? Atropine. So this may, what if you see a 28-year-old, we'll put this in non-military terms. No, we'll put it in military terms. If you start seeing multiple people coming into an encampment where you're at and they're all tearing up, they're all coughing, they got lots of secretions coming out of their mouth, a couple of them are just dropping, other ones are kind of still making it in, what in your mind are you thinking is going on? What just happened to them? Chemical. They got either into some insecticides or some sarin gas, something like that. And what does sarin gas do? It prevents the breakdown of acetylcholine. It inhibits acetylcholine esterase. Acetylcholine esterase breaks down acetylcholine. What does acetylcholine do? Makes the heart stop, makes the heart go slow, right? So that's how a nerve gas works, is it causes your body's producing normal acetylcholine, but it can't break it down because of that nerve gas. And so you then are stuck going, oh my gosh, this person's heart rate is 30. They're secreting everywhere, vomiting, defecating on themselves. What drug do you give them? Atropine, exactly. That speeds up the heart rate. And then what's the other drug you give?
Chloride.
Yeah, 2-PAM. And 2-PAM causes the chemical that breaks down acetylcholine to get reactivated again, in the just most basic terms. So if you kind of remember it that way too, this will help you. But the parasympathetic nervous system, the kind of regulates the tone of the heart. It's acetylcholine. It's done by the vagus nerve, cranial nerve 10. It's the major parasympathetic tone on the heart. And then the other part is the sympathetic, and that's your catecholamines, your norepinephrine, right? That's your fight or flight. When you get adrenaline, norepinephrine released, it causes the heart rate to go up, your cardiac contractility to go up, and all that stuff, okay? And we'll get a little bit more into this, but if you remember, the basic baseline for the heart is the parasympathetic tone. Parasympathetic tone slows the heart rate down, and what slows the heart rate down is acetylcholine. You'll always get those questions kind of right. You'll be able to work your way, fight through those ones, okay? All right, questions on that? All right, let's keep moving. And this is just showing here that the vagus nerve, We just talked about that. Major parasympathetic player, and it goes directly to the SA node, and that's what starts your heartbeat, right? So there's a couple ways that you can stimulate this pathway, and you may have heard people in SVT, the carotid, yes, because there's receptors here that stimulate the vagus nerve and make more acetylcholine, and that slows the heart rate down if it's going super fast. So you can rub that, you can have someone Valsalva down, bear down, and it's amazing. You'll watch their heart rate go from 150 back to normal, and all you're doing is using the normal body's pathophysiology. You're just giving them a healthy dose of acetylcholine. Okay? Make sense? Sort of? Okay. All right, let's move through some of this stuff. Here's where we're gonna actually go through this. We're gonna skip through this because we're gonna get to that separately. But all right, cardiac leads. You guys need to know a little bit about this. We're not gonna waste a lot of time because this is something that you're gonna just look at lead placement when you're doing your paramedic runs. You're gonna talk to them about, and you just kind of need to know where those go. There's no point in going over it in here. It's kind of a waste of time. You just got to memorize that little diagram, okay? And I think they have these handouts, right? Everything you need to know is kind of in that if you look at it. The one point I want to make for you guys, again, so you're thinking about this because it's going to help you, is each of these leads that we talk about, each one that causes a different picture of the heart, corresponds to an area on the heart, like the inferior wall of the heart, like the anterior wall of the heart, like the posterior wall of the heart, and the lateral part of the heart. So these leads correspond with those areas of the heart, which corresponds with where people have what? Heart attacks, right? So that's why when you hear someone say, oh, where do you look for an inferior wall MI? You look in the leads that are on that part of the heart. It's not rocket science. Those leads are stuck right over the part of the heart that's the inferior wall of the heart. And it just so happens that those leads over the brilliant people make this stuff up. They figured out that that's lead 2, 3, and AVF, your inferior leads. So every time you see an abnormal pattern in leads 2, 3, and AVF, you just know, oh, that's just the inferior part of the heart we're talking about. So it kind of demystifies that a little bit. And we'll go over that when we talk about heart attacks ad nauseum. You guys you'll leave here, the three of you will leave here, and you'll get every question right on your test when it comes to that. All right. Right-sided leads come in very handy when you talk about posterior wall MI. That is the test question, all right? Patient comes in and has deep ST depressions. They're hypotensive, tachycardia, sweating, pale diaphoretic. You see deep depressions. What is your next move? The answer is to get either right-sided or posterior leads, okay? We'll talk about that as well. All right, access. Access is a question that does pop up on the paramedic boards. It's a very confusing topic, but it's simply this, okay? It's simply the overall impulse. If you took all the electrical activity in the heart and you just randomly drew a line on average which way that impulse was going through the heart, that's what access is talking about. And it's super easy to figure out, okay? And you're going to want to write this down if you don't have it, because you'll get every question right again. And it's called the thumb method, okay? Are you guys familiar with that? Have you talked about that? Okay, if you go to leads 1 and AVF on your EKG, if you just find lead 1 and AVF on your EKG, okay? And then you go, the thumb method, this is a little bit confusing. I got this wrong. I was tricked by this last time I gave this lecture 3 classes ago, I think. This is lead 1. So if you lead 1, the QRS complex, okay? The QRS complex, you're comfortable with what that means? That's the, QRS complex. You got your QRS, it's the big, yep, that's your QRS complex. If in lead 1, it's upright, means if you hold your thumb on it and the major part of that QRS complex is going upright, that's called positive. And in AVF, if it's upright, okay, that's called a normal axis deviation. Here, use this one, it's a little better to look at. And then correspondingly, if you're upright in lead 1, but you're down in lead AVF, okay? So you look at AVF, if the maximum impulse is going down, the QRS complex is mainly down, then you know your left axis deviated. The exact opposite, your right axis deviated. This again is just something you just put down on a piece of paper if you don't have it yet, and you memorize that last minute for the test. And the reason that you need to know this is because left heart and right heart axis deviation corresponds beautifully with several important illnesses, okay? The one that will show up time and time again that they'll give you a clue on the test is you'll have a EKG with a right axis deviation, okay? And you'll say, then they'll ask you, which of the following, these are nearly impossible to read, but which of the following illnesses, or what would be your next step? And it's what they'll get at is like a pulmonary embolism will cause a right axis deviation. Okay, COPD will cause a right axis, but a real classic one is pulmonary hypertension or anything pulmonary embolism, all deviate you to the right. Don't overthink this. You don't have to understand this for the paramedic test, okay? You don't have to, really. What you do need to be able to do is know whether it's left axis, right axis, or normal. They will not ask you anything about no man's land. I guarantee it. There's no good question that you can put on a paramedic board about no man's land.
So no man's land is what though? Is that
Both down. That's when you look at the EKG, and both 1 and AVF are both down.
What does that refer to on the heart though? What area?
It doesn't refer. Remember, these are average energy field. Yeah. So it doesn't refer to one specific part on the heart. It refers to the overall thrust of the electrical capacity through the heart. Okay, it's probably the best way to think about that. So the axis deviations, and the two that you need to know, if you get a chance to review, is just what happens when you're in left axis deviated and what happens when you're in right axis deviated. Know a couple of the big things that you see in both of those, and this will be a clue on your test. Okay, and they might just ask you. They might give you an EKG, a normal-looking EKG, and say which axis is represented. A patient with, whatever comes in, what axis does this EKG represent? And then if you just remember this little trick, the up-down, lead 1, and AVF, and you just go to that on your exam. Is your exam computerized? I think it is. And hold okay, so this one's down. That's left axis deviated. Boom, you got the question. Do you understand axis? Not really. Do you get everything about it? Again, Dr. Garner would be in here dropping terms that make no sense to any of us because he's so smart when it comes to this stuff. But this will get you your test question right, okay? And this also may actually help you someday in real life because you can look at an EKG and go, man, I don't know what's going on, but look, this thing's clearly right axis deviated. So this is either pulmonary hypertension, a pulmonary embolism. Hey, you know what? I bet this guy's got a PE. He's short of breath, he's tachycardic. A piece of the puzzle. Does that make sense? Actually does help you in real life. Okay. All right. EKG, we're going to go to just basic EKG reading and what this means, okay? So first thing you've got to know, you got to have a good technique, however you guys want to do, but how to do your rate. Super, super important. You'll get test questions right just on knowing cardiac rate. So heart rate of 50 is 6 blocks, okay? 6 big blocks, okay? Heart rate of 50. So you've got 1, 2.5. Yeah, good. Let's see. You've got, between the QRS complexes, you've got 1, 2, 3 full blocks, okay? Mm-hmm. That's what we're talking about. Does that make sense? Those are the blocks we're talking about. So in between, when I say big blocks, I'm talking about,
1, 2, 3 big blocks.
Yep. You got 1, 2, 3 big blocks plus maybe a half and a half, right? So maybe a total of 4 big blocks total. Okay? And then this is what those mean. So if you have 6 big blocks between your QRS complexes, your heart rate's 50. If you have 5 big blocks, your heart rate's 60. If you have 4, it's 75. If you have 3 big blocks, it's 100. If you only have 2, it's 150. And if you have 1, it's 300. Okay? That's a really quick and dirty way. It's easy to remember. Before your test, you write that down 3 or 4 times because they won't give you the rate on the test. They'll just throw you an EKG. And it makes a difference because, for example, if someone's heart rate is going, say, 100 if you have a wide complex tachycardia and it's going 90 beats per minute, does that necessarily need to be cardioverted? Is that necessarily VTAC? No, right. But if you just say, it's wide complex, it's going fast, that's VTAC, you get the question wrong. But you'll say that's wide complex and it's going 150 beats, that's VTAC. Okay? So make sure you kind of get that. You do it however, there's all kinds of ways to do that. You do whatever you're comfortable with. Intervals, again, real quick. P to R interval, what does that represent? The time it takes from the SA node to get to through the AV to the ventricle. That's the ventricle firing. So here it's SA node has fired, it's gone through the AV node and now hit the ventricle, and this is the ventricle firing. Okay? All right. This is the ventricle repolarizing, and that's where we see our heart attacks. And again, don't belabor too much on that. Okay? All right, how to interpret an EKG. Let's go to this picture here. Absolutely critical for your test is to recognize tachycardia and bradycardia. I know that sounds super simple, but it's critical, all right? And we just talked about the box method. The next most critical thing for you to really kind of start keying in on is the rhythm, okay? And usually on an EKG or a rhythm strip that you'll be presented with, there'll be one lead, and if you look on your EKGs that you got in front of you, at the bottom, there's a single lead rhythm strip. You see that down there? Yep, usually that you're going to be given that, okay? Sometimes you have to fish it out of the EKG itself, but the rhythm is super important. And what I mean by that is it regular? Is it going boom, boom, boom? QRS complexes is what I'm booming over, okay? QRS complex, QRS complex, QRS complex, QRS complex, QRS complex. Or is it going QRS complex, QRS complex, QRS complex, QRS complex, QRS complex? It's irregular. You hear that? You can kind of hear it and visualize it at the same time on your EKG. So if you're a regular rhythm, okay, and you have a P wave before every QRS complex, that's considered to be a sinus rhythm of some sort. Sinus tachycardia, sinus bradycardia, whatever, but it's a regular rhythm. If it's irregular, okay, what if it's irregular and you can't see clear P waves in front of every QRS complex? What might that be? You have a...
You can't see a P wave, you said?
Yeah.
Like a PVC?
Okay. Yeah, that'll do it. How about atrial fib? That's classic AFib. And that's what you'll see on your test. Guarantee you're going to get a test question on AFib. Okay? Irregular heartbeat with no good QRS or no good P waves, AFib. All right? Till proven otherwise. All right. So for you guys, you want to recognize the rate, recognize the rhythm. Okay? And then let's see, what else do they... and within all those things, the recognizing the rhythm, you're going to answer these questions like, is the SA node working? Is the AV node working? All of that stuff. And we'll talk more about that in a minute. And then the last thing that you really, really need to be able to identify is whether it's a wide complex QRS or a narrow complex QRS. Okay, we'll talk more about that again in a minute. And then lastly, you need to know stone cold your MI leads. Okay? You've got to know those. Those will get you test question points every time. Okay, and we're going to burn through this so we get to that. All right, this is just giving us some examples. Here's a PSVT. Here's some bigeminy. What else? Bonus question. If you can answer this, you got it rock on. Let's say this patient comes into you with muffled heart sounds, JVD, equal breath sounds. Breath sounds are both good, and hypotensive, and that's their EKG. What's that called? Tamponade. Do you remember what this is called? We see it in tamponade. It's electrical alternans, right? You have a big QRS and then a little one. You have a big one and a little one. It's not really that, but that's kind of what it looks like. So if you see that kind of an EKG and you get that kind of a history, it's a tamponade. Guaranteed, every time, okay? All right, and then this is the joke here. This is a 35-year-old attorney, the shark wave there. Yeah, okay, Very good. All right, arrhythmias originating in the SA node. So a sinus arrhythmia is a abnormal rhythm that has a P wave before every QRS complex, plain and simple, okay? And you can get sinus tachycardia, okay, right here. It's just a fast heartbeat with a P wave in front of every QRS complex. So you're going to be super important. You're going to want to see those things. SVT is going to be coming from above the heart from the SA node, and it's going to be a super fast heartbeat, around 150 or higher, and you're not going to see a good P wave, mainly because it's just going so fast, okay? Or from where this is originating, but we'll talk again a little bit more about it. And then you've got here an example of sinus bradycardia, okay? Sinus bradycardia can respond really well to atropine. You've got a patient with a sinus bradycardia, does well with atropine. All right. So arrhythmias in the atrium, okay? This is your AFibs, this is atrial flutter, and your multifocal atrial tachycardia. We're going to get to these more, so don't feel like we're buzzing through too fast, okay? But you're going to get, for sure, this rhythm strip or this EKG, and you'll notice it looks like almost like that shark tooth, like on the joke. Sawtooth EKG. These are the atrium firing at super, super fast, 150 to 300. And normal QRS complexes coming through. And this is atrial flutter, and it's treated basically the same as atrial fibrillation. Here we see this kind of a random baseline, maybe some P waves there, but before each and every QRS complex, there's not a clear-cut P wave. And it's very, how would you characterize the rhythm on this? Regular or irregular? Irregular, yeah, it's very irregular. Awesome. Don't worry about that yet. And then multifocal atrial tachycardia. I don't think they're going to ask you this. This is what people with bad lung disease get. And the key to this is you see different looking P waves before every QRS complex. Suppose you could get a test question on this. It's kind of difficult. They might ask you. So if you looked closely at this, and when you do your studies for your test, multifocal atrial tachycardia, it's multifocal. There's multiple foci of where that electrical impulse is starting in the atrium. So you're going to have, of course, noticeably a different looking P wave because they're coming from different spots. So that's multifocal atrial tachycardia. All right. AV node. Oh, you guys got this already because you conceptualized AV node blocks already because you know what the AV node does. So if the AV node is blocked, what's going to happen to your electrical impulse? Is it going to stop or is it going to go through? If it's blocked. It's going to block. It's going to stop. And you know what the AV node does? It slows the conduction down going into the ventricles. So you should expect to see some kind of bradycardic blockage on AV node blocks. Okay? And there are several types of those. And I guess we're going to go into those here in a little bit. Okay? The AV node blocks. That's your Mobitz type 1, your Winky-Bach. Okay? Mobitz 2. Yeah, we'll talk about those. And then rhythms originating in the ventricles. There's basically, you need to know 2, ventricular tachycardia and ventricular fibrillation. And within those, there's some variations, okay? But wide complex tachycardia is VTach. Wide complex, but really not tachycardia, don't be fooled. Okay, it's not necessarily VTach, that's what's called an idioventricular delay. The key to this, without overthinking it, is the rate that it's going at, okay? Fast, look at how many boxes, maybe 2. Heart rate, 150. Bad, right? Patient unconscious, maybe no pulse. What do you do with that rhythm? Yeah. Do you have to synchronize it? Nope, you just shock them. Bad. Here, disorganized and smaller. This looks a little bit like polymorphic VTach, like that. But this is VFib. This usually is very small on your EKG. Small, irregular. This person is, without a doubt, unresponsive. What do you do with that one? Yep, you shock it. And then this is that classic, they call it torsades. And you got this multi focal tachycardia, I guess. You just see that it makes this it's coming all kind of a crazy axis, which this is coming through at. And that also is a shockable rhythm. And you can, or give magnesium, the classic answer to that one, magnesium. Okay. All right, so AV node blocks. You got your first degree heart block. First degree heart block simply means a P to R interval greater than 20 milliseconds. Okay? It can be a little bit difficult to pick up because it's just all it is a prolongation from the P to the R of more than 20 milliseconds. Probably not super testable because there's nothing there. You don't do anything for that. You just kind of, so it's, they might show you that EKG and then you just do whatever the rest of the question is telling you to do. But now we start to get into more serious heart blocks, and we've got boy, these are not very good pictures of that. Let's go, we'll get to better pictures because it doesn't do this justice. Type 1 heart block is just basically a normal P wave, normal QRS, and then normal P wave, normal QRS, normal P wave, normal QRS, normal P wave, normal P wave, and then boom, nothing after a P wave. Okay, boom, nothing after a P wave. This is a bad rhythm. And then we don't really see the prolonging good here, so we're going to just keep going. And we'll get to this more. All right, and then there's the third degree heart block, which is where your atrium are beating independently of your ventricles. Okay, so you'll see a normal ventricular, these are really not that good, we'll get better. Normal ventricular rate, but the P waves are all crazy. That's how you pick that one up. You're like, wait a minute, this isn't even really a heart block because these P waves are just all over the place. That's a third-degree heart block. And what do you do with a third-degree heart block? Pace that person. Okay, that's electrical, this is a bad problem. They just pass out on you and stuff like that, okay? Atropine's not very effective. Okay, defibrillation, defibrillation, VTAC, VFib, you just shock those, right? When the person's unstable, you just shock those. You don't need to synchronize. What do you need to synchronize? Do you guys know those? SVT. How about AFib? AFib, yeah, you synchronize those, absolutely. So we're gonna just keep burning along here. And then again, to just beat home with you for your test, if a patient's unstable, and you'll know that, and I think you're gonna learn this in your next lecture when you're talking about cardiac output and shock, but if they show signs of end organ dysfunction, they're altered mental status, they're hypotensive, they have severe pain, they're diaphoretic, they look bad on the test, and they'll make it so you know. They're not gonna be like, he has mild diaphoresis and maybe seems a little confused. It's gonna be like a 68-year-old male presents diaphoretic, pale, unable to answer questions secondary to confusion, and his EKG shows this, and there'll be VTAC there. What is your next best step? And it'll give you amiodarone, 300 milligrams. Hi guys, come on in. Yeah. Amiodarone, 300 milligrams, synchronized cardioversion, or defibrillation. And the answer is you just shock that, defibrillation. Does that make sense? Those terms make sense? When you say synchronized, that means you're actually hitting the sync button on the thing, you're capturing them, QRS complexes. Defibrillations, you're just sending large amounts of electricity through the heart. Okay. Awesome. Brady dysrhythmias, we'll get more. That's all your ACLS stuff, you guys. And I would say for your test, you got to know ACLS cold. You'll get a lot of questions right by knowing that. Okay. So again, we're not going to waste our time having me read you algorithms, because all you need to do is spend time, put those algorithms in your memory bank, and you'll start getting test question right. Awesome. All right. This is just kind of reiterating what we said. With no pulse, you cardiovert. You got to think this is an important thing. Your 6 H's and your 6 T's. Okay, remember those. We see these in the ER all the time. We see them all the time so frequently. Many times we don't even think about them as the 6 H. These are our underlying problems of why people come in unresponsive, pulseless, needing CPR. Who was in on the CPR today with auto pulse wasn't working? That was kind of a cool case. So they have an auto pulse that this guy came in unresponsive with no pulse, but the chest compressing machine wasn't working, and everyone freaked out. It's like, wait a minute, do we not know how to do chest compressions anymore? It was kind of funny. But all right, anyways. So high performance CPR, perfect segue into CPR. Hard, deep compressions, fast. We're not going to waste time. Okay, you guys look that over. And always appropriate. This is talking about post-cardiac arrest. When not to start CPR. Again, this is stuff you just go over, because we're going to hit, for those guys who just came in, we're going to try to spend most of our time, this is a huge lecture, 48 slides, trying to get most of the time spent on rhythm recognition and your test question. How do you look at that EKG and get the test question right? Okay? So that's why we're burning through this stuff of like when to stop CPR. That's stuff for you just to read on your couch at your leisure. Okay? All right, we're good. That stops this point of the actual lecture material. So again, for those of you guys who just came in, take a look at your EKG. You need to be able to recognize rhythm. That's that bottom strip or anywhere through there. Recognize rhythm, regular, irregular, fast or slow, tachycardic or bradycardic, okay? And the rhythm strip's a great way to do that. Maybe one of these guys can show you what we had talked about if you had any further questions on that. There were some techniques for that. And then there are some very, very specific leads, okay, that if you want to write this down, do it, and we'll get this out of the way, and then you can use this as your study guide. And I can pretty much guarantee you by the time we're done, you'll get every question in this arena right that they can ask you, okay? And that's heart attacks, okay? So we're going to start off with the Widowmaker, which is the anterior wall MI. okay? And as you remember, we talked about they put those leads. Remember how those leads are named for anterior, inferior, and all that? So these are the leads in the heart that show you the anterior heart wall. That's it. And those leads are V1, V2, V3, and V4. Traditionally, there's a little crossover. The classic is V1 and V2, but V3 and V4 also anterior, okay? Now, if you see ST elevation of greater than 1 to 2 millimeters in 2 or more of any of those leads contiguously, meaning one right after the other, so V1 and V2 with ST elevation, that is an anterior wall MI. And that anterior wall MI is because the left anterior descending artery is clogged, LAD. Classic test question. They love that test question. 64-year-old male presents to your ambulance hut complaining of chest pain and shortness of breath brought by his wife. 12-lead EKG shows. And you see ST elevation in V1, V2, and V3. Which artery is most likely the culprit of this patient's underlying problem? And it'll give you several choices. The answer is left anterior descending artery every time, LAD, okay? So you've got to know those leads cold. Okay, the next most common, so we'll just go from the biggies down to the less obscure, but the big ones, is the inferior wall MI, okay? What does that mean, the inferior wall? What are we talking about? The lower wall of the heart, and okay, guess what? There's 3 cardiac leads from the EKG that show us that part of the heart. So it's no mystery, these aren't just random stuff put together. Leads 2, 3, and AVF show you the inferior wall of the heart. So if you see ST elevation in 2 or more of those leads, contiguous leads, what part of the heart's having a heart attack? The inferior wall, right. It's not rocket science. And so it's a little bit hard sometimes to remember all this, but that's it. So just don't think so much. Just go, oh man, there's ST elevation in lead 2, 3, and AVF. That's the inferior wall. We talked about that, inferior wall. What artery feeds the inferior wall? You want to know? Right coronary artery, RCA. Okay, so just write that in there. Right coronary artery. 2, 3, AVF, right coronary artery. Okay. Now we get into a couple tricky ones that they do like to throw at you. Okay, these 2 are tricky and people miss them because they're not careful. But the first one is lateral. Okay, and your lateral leads are 1 in AVL, right here. 1 in AVL, and V5 and V6. And they don't have to all be elevated. It can be ST elevation in leads 1 in AVL, and you're looking at this test question, same guy, 64-year-old, presents to your ambulance hut with chest pain, and you're going, he's a little bit elevated in 1 in AVL, but nowhere else. So that's a lateral wall MI, just the same as the anterior, okay? And then, so 1, AVL, V5, and V6, okay? ST elevations. You want to know the artery there? Circumflex artery, circumflex, okay? And then the last one is the one that they love to throw at you. This one's super, super tricky. And I'm just gonna show it to you. Let's see, no, you don't have one. Which is a posterior wall MI, okay? And a posterior wall MI is, you'll see ST depression. Oh man, what a mess have I made here. All right. You'll see only ST, this is the posterior wall MI, and you'll notice the EKG machine didn't even pick it up, okay? ST depressions with the tall R waves in V2 and V3 classically, okay? V2 and V3. ST depression only. ST depression only, okay? And then that's a posterior wall MI, and the reason it's so tricky is because you're looking for ST elevation, right? But you're going to remember now in that test when they show you that EKG, you're going to remember ST depression in V2 and V3 with a tall R wave. The R wave is the Q, R. It's that upstroke. Q is down, R is up. That tall R wave. And the classic way you maybe have seen people do this in your ER rotation or something, they'll take an EKG and they'll flip it up and look at it in the light. And then when you do that, you see, oh my gosh, there's ST elevation there. And it's simply because this is happening on the back side of the heart, the posterior wall. So everything's mirrored backwards. So if you look at it backwards by flipping it up, you see ST elevation there, okay? The test question that comes up time and time again for this one, what is the most appropriate next step for this patient? And I'll give you, it's just so tricky. They're gonna give you like, yeah, that's the answer. It's the right-sided EKG or posterior lead EKG, a right-sided EKG. That's 9 times out of 10, that's the right answer on the test. So if you go through your test question, the answers, and you see right-sided EKG, you should go back and take another look at that EKG and make sure you didn't miss a posterior wall, because you probably did. That's probably what's happening anytime you see that as an answer. Okay? So a classic way I like to remember this is if this helps you, it helps you. If not, it doesn't, is if you just do a little manual exercise, is if you chop that EKG right down the middle, boom, that's the widowmaker, man. You chop a person's heart right, that kills people. That's the LAD. Boom. And you're chopping right down V1, V2, V3, and V4. But, really V1, V2, V3. You see what I'm saying? Anterior, okay. Inferior is a loser. Okay, people who have inferior wall MIs are losers. It's an L, and you hold that L on the side of your EKG, and that reminds you it's leads 2, 3, and AVF. Your L just goes right along, leads 2, 3, and AVF. Do you see what I'm saying? So inferior people are losers. Inferior wall MIs are losers. You just put your L on that EKG. And then for the anterior, or for the lateral wall MI, you got your 2 here, and you just boom. So you take your fingers, and you put them on 2 and AVL, and V5 and V6. Okay, just like this, boom. And there you got your MI leads down. Everything, if you can just kind of remember those things, and if you've written that down, you'll get a huge, huge portion of the MI questions, which invariably show up correct. Any questions about MI?
I still don't understand about the LED.
The LAD?
Yeah.
Okay, LAD is the left anterior descending artery. It's an anterior wall MI. And it leads V1, V2, V3, and V4. If you see ST elevation in 2 or more of these leads, contiguous, so if let's say V1 and V2 are elevated, what kind of heart attack is that?
Septal.
It's septal, or also called anterior wall MI. That's how they'll refer to it. Anterior wall MI. What artery is clogged?
The left coronary artery.
Yeah, the left anterior descending artery, LAD. You'll even many times refer to this EKG as an LAD MI, left anterior descending artery blocked. Okay? Straight down. And again, it just has to do with those leads. When they put the stickers on the chest, who's doing their paramedic rotation right now? So when they put the stickers on, or when you're in the ER, you put the stickers on. Again, it seems like it's so sometimes confusing. All you're doing is you're putting stickers where over the years, brilliant people like Dr. Garner, you met, have figured out if I put leads V1, V2, V3 right through here, that's going to show me the anterior wall of the heart. Oh, and guess what artery feeds the anterior wall of the heart? Left anterior descending artery. And then what if I see ST elevation in those leads? Oh, that's a heart attack. Does that make sense to you? Okay. I think there's one other thing that I'd like to talk to you about, and that's a ST elevation in lead AVR only. It's becoming, I think, probably testable for you guys. If you got a normal EKG in a person who's having heart attack symptoms, ST elevation in AVR only is now considered to be acute ischemia, okay? It's an impending heart attack. So if you see that, man, if you see ST elevation here, go with heart attack type answer, okay? And that might be if the patient has a high blood pressure, nitrates, aspirin, proceed to the local, the hospital that does angiograms, that kind of thing, okay? Do you have any more questions about this part of thing? This MI, I'll tell you this story, and this might help solidify the posterior wall. A nurse practitioner who works in a small ER called us with a patient who she felt was just having some chest pain. They didn't have the ability to stress test, so they wanted to send the patient here. Well, in the meantime, the guy's troponin came back super elevated. And so I said, well, what's the EKG look like? And she said, well, there's really nothing to speak of. He's got some ST depressions in V2 and V3. And I'm like, because I've been doing this for a while, you go, alarm bells go off. Wait a minute, just in V2, V3? She's like, yeah. And I go, well, is there tall R waves in that lead? Yes. I go, whoa, that's a posterior wall MI. That guy's having a heart attack. You need to get him here as quickly as possible. And that was his EKG when he arrived. Okay? So again, pretty cool stuff. All right? Okay. You're up. What you got? Another little test question for you guys with that inferior wall MI. Which leads are those? 2, 3, and AVF. It's your loser leads, all right? 2, 3, AVF. If a person is hypotensive with those leads, you probably don't want to give them nitro. You'll give them IV fluids, okay? So on your test, if you see the loser We have it in MI because it's the inferior leads. They love to ask you, because what's the treatment for it? What do you give? Nitro, morphine, aspirin, whatever. They love to ask, they'll put nitrates. And the answer to that question is no, you give that guy volume to help support him. Okay, he needs volume if he's hypotensive. So in an inferior wall MI, which is your L, your loser leads. Losers are inferior, they have MIs. In those leads, if they're hypotensive, you give them fluids. That's going to be a test question. If you see it on your test, just send a text to someone, let them know. A couple more test questions because we don't have time to go over a lot of test questions today. I wish I was giving you guys another lecture because we'd nail this stuff. But be very careful when they give you questions about whether a patient's unstable or stable. If a patient's unstable, many, many, many times your answer is electricity. Okay? If it's a wide complex tachyarrhythmia, what is it? What are you thinking? VTach. Okay? Wide complex. Big. See that? They're wide, big. And there's actual milliseconds that correspond to these. I don't know. Don't quote me. I don't know it's worth you guys memorizing all. It has to be greater than 20 milliseconds because they're on the test. It's a computerized test. They're not going to give you something that's 2 milliseconds narrower than VTach and then expect you to get the right answer. I highly, highly doubt that. They're going to make it wide, complex like this. Understand when I say wide? This is a QRS complex, and it's really far apart. It's not skinny like the ones you have in front of you. That's called wide complex. It's a wide complex, and is this a tachycardia or bradycardia? It's tachycardic. You don't even really need to have your little box system we talked about down. You can see that that's going fast. But be careful. Don't get tricked by that. Because they'll give you this same EKG, a wide complex rhythm, that's going 80 beats per minute. Do you shock that? A wide complex going 80 beats a minute and the guy's talking to you? What? No. Okay. What's this one?
Torsades.
Okay. Yeah, you could say torsades. I like that. What else could it be? Man, so much good stuff to talk about. All right, let's go over one more EKG that's going to show on your test for sure. Two more things. SVT will be on your test for sure. SVT, okay? Almost always it's going to be somewhere above 150. It's going to be a narrow complex regular, okay? That's SVT. There's two things that they like to get you on. A 36-year-old female walks into your ambulance hut. So there's the answer to your question right there. What did she do? She walked into she's stable. She walks in. She says she's having some mild chest discomfort. And you're going to go, well, wait, chest pain means they're unstable. No, she walks in. She's talking to you. Heart rate's 170. Here's your EKG. Boom. And they show you a narrow, complex, fast heartbeat. What is the choice of the medicine of choice? Okay, vagal. Boom. That's a good point. They may ask you that to attempt the vagal maneuvers. Rub the internal carotid, have them do a Valsalva, blow into a straw. That's the right answer if they put that. Adenosine. Adenosine is your next right answer, okay? 6 milligrams, a 6-pack of adenosine, followed by a 12-pack.
If they're unstable.
Okay.
Unstable, you do
If they're
stable gets drugs, unstable gets electricity.
boom, there you go. Stable gets what he pointed out first, which is right. Vagal maneuvers first, which you hear in the ER. Sometimes we just bypass and go right to the med, but it's worth trying. I've had people come out before with the vagal maneuvers. Vagal maneuvers first for SVT, then adenosine. If you give them 6 milligrams and that doesn't work, you give them 12 milligrams. So 6-pack first and then a 12-pack to help you remember with adenosine. Okay? 6-pack, 12-pack, adenosine. And that's SVT. Okay? And that same EKG, they'll give you the same exact EKG, super fast, narrow, complex, and it'll be a 36-year-old female comes in slurring her speech, found on the couch by her husband, minimally responsive. He's concerned that she may have overdosed. So they throw that in there to throw you off, or he's concerned, whatever, they throw some little thing in there. But you see that same EKG. What do you do with that person? Her heart rate's 170. Is she stable? No, she's unstable. And you cardiovert that. Synchronized or unsynchronized? Synchronized. Exactly right. That's a test question you're going to get right. Okay? No, AV heart blocks are going slow and dropping beats. This thing's just ripping along, right? So that's atrial fibrillation every single time. Irregularly irregular, Means it's got no set fixed pattern, irregularly irregular, no clear P waves, atrial fibrillation. Okay? Same exact algorithm for atrial fib as for SVT. If you come, this guy comes into your ambulance shed. This is the EKG, shows you he's talking to you. He's awake. He says he feels a little bit, got a little tightness here, but he's got stable vital signs. Do you give this guy meds or do you shock him? If he's awake, he's talking to you, he's stable. Meds. Do you know what meds you give to AFib with rapid ventricular response? It'll be on your test. It's a fair test question. It's Cardizem. Cardizem. Okay? Cardizem. Yeah, Cardizem, calcium channel blocker. Yeah. And when you come down to the ER, I can almost guarantee you're going to see a patient come in with this and get put on a Cardizem drip. And it slows that all down. Won't take them out of atrial fibrillation, it just slows them all down. What if this patient comes in, his heart rate is 60/40, he's pale, he's diaphoretic, but he's talking to you, he's awake and alert and he's talking to you. He's having some chest pain with this. Okay? What else? Is he stable or unstable? Heart rate or blood pressure is 60/40. He's unstable. There you go. Boom. Don't get fooled. He's hypotensive. He's tachycardic. He's diaphoretic. He's having some chest. He's unstable. Okay. What happens to him? Does he get medicine or shocked? Gets shocked. Synchronized or unsynchronized? Synchronized. Yeah. And you guys, when you come and you're in the ER, come and see me. We'll go over all this stuff. I'll just pepper you with test questions again with this stuff. Okay. And then you're going to get this stuff right. All right. All right. I think we're almost out of time, huh? We doing okay? Time? I think we're right up against the edge. So there are some. I'll need these ones back. Know your heart blocks. We haven't even gone into heart blocks. They're pretty darn simple to understand once you realize what's happening. The conduction's not going through the AV node. Okay, and when you come see me in the ER, I'll go over heart blocks with you again, and you'll get those test questions right. I think you've got a whole lecture coming up on that stuff, but repetition is the key to this. Okay, repetition is the key. Look at those EKGs, pass those around. Make sure you get those walls, the inferior, anterior and lateral. And if you have any questions, if you want to go over that again, I know we burned through that fast. Find me on shift.